Hello, in this video we'll be discussing a corpus callosotomy for seizure palliation. In corpus callosotomies, the goal of the surgery is to isolate the seizure activity and disrupt the white matter tract connecting the two hemispheres, and therefore seizure propagation. All epilepsy patients that are being considered for a surgical intervention should be reviewed by a multidisciplinary team consisting of an epileptologist, a neurosurgeon, and a radiologist to review all relevant imaging. Because a collosotomy is a palliative procedure and does not achieve a cure, it is not a suitable option for patients with a resectable seizure focus. Prior to beginning the operative procedure, there are a few nuances for anesthesia and positioning. The majority of corpus callosotomy patients are relatively young and do not have additional medical comorbidities that would interfere with the progression of surgery. Unlike other surgeries performed to treat epilepsy, the success of a corpus callosotomy is not predicted by electrocorticography, and therefore sedation and paralytics may be used by anesthesia. Due to the risk of an air embolism, if the patient's head is raised, a precordial Doppler must be placed on the patient's chest and is monitored throughout the case. After induction of general anesthesia, the patient is placed in 3-point clamp fixation and positioned supine, with the head kept straight to preserve the surgeon's anterior-posterior orientation. The authors prefer a U-shaped incision with proper exposure for the craniotomy. However, a linear incision may also be used as long as the craniotomy focus lands with the midpoint just anterior to the coronal suture and extending just lateral to midline on the contralateral side. Once the craniotomy is completed and the dura is opened and retracted immediately towards the sigmoid sinus, as denoted by the blue highlight. Excessive retraction of dura should be avoided to prevent occlusion of the sinus. Subsequently, the interhemispheric fissure is entered and carefully divided. Exposure is enhanced by utilization of a self-retaining retractor. It is important to be conscious of adhesions that must be divided between the frontal lobes. The collosomarginal and the pericallosal arteries must be identified, keeping in mind to stay medial to these arteries so as to avoid violation of small perforators. The corpus callosum itself is identified by its characteristic glossy white appearance. It is important to distinguish the corpus callosum from fused cingulate gyri and take care to separate the adherent cinguli. After proper identification of the corpus callosum, neuronavigational guidance can be utilized to determine the posterior extent of the resection. The collosotomy begins 3 cm posterior to the genu, where the midline is easier to identify. Resection proceeds ventrally to the midline, leaves of the septum pellucidum, and then anteriorly to the anterior commissure. A combination of suction and bipolar cautery, microdissector, or carbon dioxide laser may be used to perform the disconnection. In this video, a carbon dioxide laser is utilized. If complete disconnection is the goal, take note that a larger craniotomy must be performed, or this can be accomplished through multiple craniotomies. During the posterior collosotomy, the intercerebral veins and the vein of Galen just below the splenium pose a hazard. Identification of the deep cerebral veins through the arachnoid signals completion of the dissection itself. Additionally, in the posterior callosal division, it is important that the dissection remain midline and is advanced cautiously to avoid injuring the fornices located just below the corpus callosum. Care is taken to identify and preserve the anterior cerebral arteries and associate perforators during the final anterior dissection. On completion of the goals of the surgery during the corpus callosotomy, after adequate hemostasis, the craniotomy is closed in the standard fashion. Thank you.